So when he said that, still, I kept thinking about it. I'm a great believer of luck, of destiny. In October '84, Dr. Jahara Paul, myself, I'm sure, who else was there? Never mind. And so we were examining for MCPS. When the exam finished, Jahara invited us to her place for dinner. There were a few other gynecologists. So one of the gynecologists asked Jahara, on 1st of November, we are having a gynec society meeting. Please do come. She said, oh, not first. I'll be in Melbourne. So I was standing there. I said, why Melbourne? She said, Monash people are having their second workshop in IVF. I'm going to attend. She was being sponsored by Army. She was then brigadier. So I said, if you give me the address and telephone number of Monash people, I like to attend. She was very good. Normally we become constipated. We don't share information. So immediately she gave me the number and address. So those days were days of fax. So I reached Lahore next morning and sent a fax that I would like to attend your next workshop on 1st of November. And luckily they had a place, so they faxed back, you're welcome. Well, within a day, Saqib Siddiq was my registrar those days. I asked him to get NOC. He was good in dealing with Secretariat. So he brought NOC. Believe it, before first I was in Melbourne. This is what I call destiny. Jahara gave me the number. I called and they had a place, so I reached there. The workshop was for nearly a month. I took detailed notes of everything because those days information about IVF was not shared by few centers who were doing it. When I had written a letter to Professor Howard Jones, with whom I had worked in Johns Hopkins, America, that I would like to come and see your center because they were first Americans to produce the baby. He said, yes, you come and see our clinical work, but you will not be allowed to enter the lab because of infection and care. Anyway, Monash people gave us totally open information. But mind you, 84, if I tell you, you have to believe it. Culture medium was prepared in Monash with various salts, NLR salts. And laparoscopically, ovum pickup was carried out. Monitoring was only by estradiol test, E2. There was no ultrasound, no TVS, and no prepared culture medium. So I brought back that information. Those days, Farrukh, Zaman, and Saqib, we all worked in the same department. So I asked them, would you like to be member of the team? Because it couldn't be done in services hospital, at the government hospital, because there are no funds. They agreed, so we made the team, and if I tell you, that is also correct. We worked out how much money we needed to set up IVF in '84. It came to 25 lakhs then, which was a lot of money. I didn't have that money. And I asked my rich friends to buy share in this. They are to date shareholders of more than 50% shares in this company. They are sleeping partners, but every month my son Harun sends them a hefty check. So good investment. Then we started our IVF program, very difficult technologically. Preparing culture medium, its pH, its osmolarity, all that was difficult. But Farrukh and Saqib, our embryologist, he doesn't live in Pakistan anymore, Tahir, they all worked at it. I have a long story about our success, but for this talk, our real success came after 5 years. You know, if you work at some project, something, and you're not succeeding, 5 years is a long, long time. All the time, my friends kept telling me, sir, kuch nahi nikalna, 2-4 AC बिक जाएंगे, थोड़े incubator भी नहीं कोई खरीदेगा, छड्डो, कुछ नहीं निकलना. But I must compliment my members of the team, Farrukh and Saqib and Tahir. We kept at it. Eventually, we had success. And that was 89, we had the baby, first Pakistani baby. That time, the religious scholars, they didn't know what IVF was and how it was done. So generally, anything new, they have negative view. They have negative view about it. But we went to their houses, their workplaces, explained to them. And we coined this terminology, if for heart, artery is blocked, bypass is allowed. And that is life-saving. In case of IVF, tubes are blocked, they are bypassed, and that is marriage-saving. So it appealed to them. And once it was explained like that, those who were anti, they became friends. To date, they are friends. So the lesson, second lesson for this exercise is, if somebody is against you, approach him, approach her, reach out, explain your viewpoint. Generally, they will be compromised. He'll understand your point of view, and there'll be peace. There'll be peace. Very important. Then we created, once this IVF success came, we created IVF Society of Pakistan. Way back. Few centers kept coming up, but the society remained sort of silent or went into slumber. No activity on behalf of that. Although Farrukh arranged 2 or 3 international meetings for that IVF society. But still, because, you know, if some Australian is sitting here, for 1 million population, there is 1 IVF center in Australia. We are 200 million, and I don't think we have 20 centers. We need 200 centers. So there are very few centers. Morally, socially, ethically, I would say, it is our responsibility to provide this service to our patients. Because 20% of the population needs your help. And unfortunately, because there are no centers, no place where they can call and seek help is not there. So I would say the IVF Society is not active society at the moment. It hasn't been active. But the younger generation like Sadiah and others, they should infuse life into it. They should make it active. There are a lot of things which collectively, through the society, we can do. We can influence our mullahs about ethical issues, about PMDC, about our social and every issue. A society can speak better than individuals. When individuals speak, the other person thinks it's his personal interest. When the society will speak, it will be for the public, for health care of our women, our infertile couples, or subfertile couples. So I finish here. First, compliments for organizing this conference. As a side branch or shoot, we are talking about IVF Society. Compliments to the madam, and keep it up. I hope something positive and constructive comes out of it. Thank you very much.
Thanks a lot, Prof. Very interesting success story, and you are an excellent storyteller. So our next speaker is Dr. Sadiah Hassan Paul.
Thank you. So I'm going to be very brief. All I'm going to say is, this came as news to me as well, that IVF or all infertility treatment has now been taken seriously by the WHO as well as a sexual and human right, sexual health right. So I'll just briefly go through this. And so basically, these are the WHO 6 building blocks for the health system. Leadership, governance, health system, all these things integrate together. Financing, workforce. We all know this theoretical stuff, except, at least in Pakistan, it doesn't seem to be happening as it should. But anyway, it's there. So briefly, what are the essential sexual and reproductive health services? Essential meaning this must be provided to all. Accurate information and counseling on sexual and reproductive health, including evidence-based comprehensive sexuality education. And by this, I mean that, it includes school health as well as premarital counseling, adolescent health. So information, counseling, and care related to sexual function and satisfaction, voluntary, informed, and affordable family planning services, safe and effective preconception, antenatal childbirth, and postnatal care, safe and accessible post-abortion care where legal access to safe abortion services have to be provided. And I've highlighted it, prevention, management, and treatment of infertility. This is also a health right. And previously, my own Dr. Rizwana is here. We were both together at this meeting, this consultative meeting, where we have thrashed out the evidence-based guidelines. And these will soon be coming out as a very comprehensive, very easy to follow book on all these aspects of sexual and reproductive health, which makes our job a lot easier. So previously, my understanding was that IVF or infertility treatment is a luxury, especially for countries like Pakistan, a developing country, a poor country, and which is overpopulated. But then, as we all experience in our practices, both are creating huge problems in our society, culture-wise, and the outfall or the consequence of having too many babies and the consequence of not having any babies. So I will just skip through this mostly. However, the WHO recommendations on SHRH, which means it should include management of subfertility and infertility, STI prevention and fertility awareness, optimal timing of intercourse, the risk factors, identification and referral of fertile couples at the right time. Don't keep them, in cycles of clomiphene for years and years and years, till the time that they've lost their eggs and fertility is down in the boots. So all these management options, including ovulation induction, IUI, surgery for blocked tubes, ART, adoption surrogacy, this whole spectrum comes, and there's an article in the Lancet, if any of you, very comprehensively written article, May 2018. You can Google it and read it as well. So sexual rights are human rights, and unfortunately, most of us who are in clinical medicine, we're not really in sync with the public health aspects of the profession we practice, and I think we need to integrate all that we're doing with what is required in public health as well. So I won't go through this list, but there is a continuum of care along the life course. So it doesn't stop, really. Interventions need to be delivered at the appropriate stage of life to maximize impact. So they help in reducing morbidity and mortality in the next stage of life, if you've made the right intervention. So adolescent and youth need to be counseled, need to be informed about sexual health. Pre-pregnancy counseling and care, pregnancy care, throughout birth care, the postnatal period care, which includes family planning, the newborn period, infancy and childhood, interpregnant period for the women, meaning in between babies. And we added to this menopause management as well when you're talking about continuum of care. And this is a relatively new concept of self-care, which is really applicable to our country because this is sort of emphasizing on care at home, which is already happening in Pakistan. Self-medication, खुद से जाके डॉक्टर को कंसल्ट किए बगैर जाके दवाइयाँ ले लीं, खा भी लिया, गूगल करके देख लिया, stuff like that. But if they are following the right path or the right direction, it saves time, it does save a lot of money, and there are places where there may be no access to healthcare. So at the same time, they need education so that there is a limit to which they can do self-care and then refer themselves to a health center. So I will not go any further except to say that once these guidelines come in, you can even get most of it on WHO websites, we need to adopt these guidelines into our practice. And in the service provision, develop innovative strategies, and strengthening the outreach community as well, and have a proper referral system. So this was just an introduction to it. I just wanted to sensitize you people that here we are talking about infertility, but there is a huge public health aspect of it, which is in continuation from birth till beyond menopause. And I'd like to end with saying that this is, we're talking about infertility treatment, and a couple of days back was World Contraception Day. Okay, the other extreme. Very important that we all should be, doing both things, addressing the needs of all the women as required, having the number of babies that they want. Not less, not more, but whatever ideal size that they're aiming for, they should be able to get it, and we should try to help them. Thank you.
Thank you very much, Dr. Sadiah, for your comprehensive and very informative talk. Our next topic is about infertility management guideline, and it will be conducted by Professor Farrukh Zaman. A brief introduction will be provided by Dr. Sobia. Please come to the stage.
Assalamu alaikum all. First of all, congratulations to Dr. Sadiah, Hassan and Concept Fertility Center for arranging such a brilliant conference for infertility, which by all means is the need of the time. Our problem might be of population. However, we cannot neglect the fact that 15 to 20% of couples in our population are infertile or subfertile who face the problem of infertility and have a logical need and desire for having a baby. For women especially, being a mother is an instinctive need to complete her life, and therefore it consumes a great proportion of their physical and mental well-being. In view of this, it is imperative for the medical profession to help these couples as far as possible in achieving a pregnancy and enjoy this blessing. To standardize practices and to provide uniform guidance based on evidence-based published literature to OBGYN specialties as well as family physicians, it is important that guidelines should be developed. Professor Dr. Rashid Lateef introduced the IVF Society of Pakistan, and in collaboration with the IVF Society of Pakistan, we have developed a consensus statement and group practices of Pakistan in infertility management in Pakistan. For this, I would like to call upon Professor Farrukh Zaman, who is Professor OBGY, and he is retired from government services as Principal of Postgraduate Medical Institute, Lahore. He is now Dean and Professor of OBGY of Rashid Lateef Medical College, Lahore. And I'm very much honored that Sir would be introducing these guidelines to you and launching this document, as he's one of the members of the team who introduced the first test tube baby in Southeast Asia, Pakistan. Please welcome Dr. Farrukh Zaman.
Thank you, Dr. Sobia. At the outset, I must thank Mrs. Abbott for taking this initiative of assembling various professionals from the IVF centers and also office bearers of IVF Society of Pakistan in formulating the guidelines, infertility management guidelines. As Professor Rashid Lateef in his introductory remarks about the society mentioned, that it is the responsibility of professionals in the specialty of obstetrics and gynecology, and particularly those who are involved in the management of infertility, that we create awareness amongst other health professionals and also amongst the public about the safe practices and how to go about the management of infertility. In that direction, these guidelines have been formulated, and I would like to extend my gratitude to the colleagues who have taken part in the formulation of these guidelines: Professor Sadiah Hassan, Professor Shaheen Zafar, Professor Arshad Chohan, Professor Yusuf Lateef Khan, Professor Saqib Siddiq, Professor and in addition Dr. Naseem from Islamabad, and Dr. Ijaz Ahmed from Multan. They all have participated in that, and Dr. Sobia Ali from Abbott, she was the person who was coordinating all these efforts. The guidelines book has been published, and it will be available to all those who would be going out of the hall from now onwards. I am sure at this time they are going to open the boxes and make it available. As has already been said, the aim of this document is to aid the healthcare professionals in everyday clinical decisions about appropriate and effective care of their patients reporting to them with complaints of infertility. And also, it is important to realize at the same time, like most of the guidelines, that the clinical judgment of the individual practitioner is not to be overridden by these guidelines, and these are only provided to as a framework upon which to base. The important thing is to individualize the management. The topics which are covered in these guidelines are given in this list. Initially, there's an overview of infertility, workup and testing, and counseling, which is again very important, and then a detailed description of various components of assisted reproductive techniques, and then at the end, the early management of pregnancy as a result of assisted reproductive techniques and the management of complications of assisted reproductive technique procedures. The overview deals with the causes of infertility. Workup gives detail about the evaluation of partners and comprehensive history, physical examination, and timing of evaluation, which again is important, that if a comparatively younger couple is there, then you may take your time in investigating and all that, during which it is expected that there may occur a natural conception. But if the age of the woman particularly is 35 or over, then there is a need for some urgency. Similarly, a few misconceptions about husband semen analysis and semen values, which are prevalent particularly amongst the family physicians here and even some of the specialists. Those are addressed in this section, and it is important that we all become aware of WHO guidelines and WHO parameters of semen values. Similarly, various methods of ovulation evaluation and tubal patency. And then when the area of the counseling of the couple, which has to take into account the individual circumstances and situation of that particular couple, and therefore that counseling has to be individualized in their own context. And at the outset, it is important that the expectations from the procedure and many other myths about fertility or the other areas associated with it, they are to be clarified and they are to be put into proper perspective. These various steps, as far as possible in lay person's terminologies or lay person's language, has to be explained to the couple, and these are also given in these guidelines. And finally, the early pregnancy management following ART pregnancy, because that too is important. Although the couple would be going to other OBGY specialists for management of the pregnancy, but the management of early pregnancy of the first trimester, that is to be guided by people who carry out assisted reproductive procedures. So this is a kind of summary of what the information is given in this booklet, and I'm sure that you are going to have an enjoyable read of this. And this is the booklet. The color scheme was already there, and when you go out, please collect your copy of this guideline, and also they'll be available from the Abbott stall.
It's in everybody's bag already.
They're already in the bag?
Yes, yes.
No.
Those who don't have it can collect it, yes?
They must have been included in the bag from midday onwards, not earlier on.
So the ones who are
So
not
they are
having
going
this
to be,
bag,
they are available anyway,
yeah.
they are available outside.
Yeah.
Thank you very
Thank
much.
you.
Maybe from the Abbott stall, you should book your copy there, yeah.
Thank you very much, Prof. Farrukh, for your brief but very informative information. Next topic is Luteal Support, Evidence-Based Management, and it will be conducted by Prof. Arshad Chohan. Regarding Prof. Arshad, he is renowned gynecologist, author of textbook in Obs and Gynae, and there are more than 30 research papers credited to his account, and he runs a free annual course for FCPS and MRCOG candidates in Lahore, but only in Lahore. I don't know why not Karachi. And he served as chairman Obs and Gynae, King Edward Medical University, Lahore, and he served as dean faculty Obs and Gynae CPSP, and he is CEO of Craft IVF Lahore. He organized 3 international conferences under the banner of Craft IVF. So please welcome Prof. Arshad Chohan.
बिस्मिल्लाहिर्रहमानिर्रहीम। जितने जोश से आपने तालियां बजाई हैं उस हिसाब से तो बंदा वापस लाहौर ही चला जाए। वो लड़की जो बड़ी मेहनत से मेरा इंट्रोडक्शन लिख के लाई थी, 4 दफ़ा उसने लिखा, 6 दफ़ा उसने मिटाया, और फिर उसने ज़ोर ज़ोर से आपको बताया कि स्पीकर इज़ कमिंग, तो आपने 2.5 तालियों से इस्तकबाल कर दिया। एनीवे, ऑनरेबल सीनियर प्रोफेसर्स, माय टीचर्स, colleagues, ladies and gentlemen, it's always a pleasure to come to Karachi and talk to the audience. अब जब से पैदा हुए हैं हम सोचते सुनते आए हैं कि पढ़े लिखे लोग सिर्फ कराची में होते हैं, और कराची वाले ये कहने में दरेग नहीं रखते कि लाहौर वाले खोते खाते हैं। हम खोते पकाने वालों को पकड़ते हैं, आप चुप करके खा जाते हैं, इसलिए हम उतने खोते नहीं खाते जितने आप समझते हैं। I have been assigned with the topic, which is a specialized topic, and many of you would not be involved actively in the management, so it may turn boring. I will try to keep it alive as far as it is possible. Luteal phase support. When we talk about IVF, we have learned a lot and we have gone miles into the field of ART. But when we make an embryo and we post it to uterus, subsequent to that, we are unable to do anything at the moment. And what we are looking at is what is the dialogue between the baby and the endometrium. Why the dialogue fails? Is it related to the baby? Is it related to the uterus? Or is it related to the overall biochemical environment of the body of that woman in which the embryo is placed? हम जब पेशेंट को रिपोर्ट देते हैं आफ्टर कंक्लूडिंग, जिस दिन एम्ब्रियो ट्रांसफ़र करते हैं, तो हम कई दफ़ा उनको बड़ी अच्छी अच्छी बातें कहते हैं कि इट इज़ अ वंडरफुल एम्ब्रियो या ब्लास्टोसिस्ट, हम बहुत अच्छा प्रोसीजर हुआ है, और उससे पेशेंट्स की होप्स बिल्ड हो जाती हैं। बट व्हेन द साइकिल फेल्स एट द एंड ऑफ द डे, देन वी आर डिसअपॉइंटेड, और पेशेंट जब हमें पूछता है कि क्यों हुआ है, तो हमारे पास बहुत सारे सवालों के जवाब नहीं होते। It is a complicated process of implantation, but for that we need a functional corpus luteum which produces estrogen and progesterone, which develops the endometrium, prepares the endometrium to receive the implant, and then maintain the pregnancy. We all must understand that endometrium goes through different phases. We know the follicular phase, we know the secretory phase, but within the secretory phase, there are only 3 restricted days, which is called a window of implantation. That surrounds day 20. It starts from day 19 and it goes to day 22, 23. If the window of implantation is not in coordination with the delivery of the embryo to the uterus, to the endometrium, the implantation will not occur. So we need to make sure that the woman develops the implantation window and the embryo is transferred during that window, when a typical structure is formed in the endometrium which is called pinopodes, and they negotiate with the baby and they give implantation or a combination to the wall. To understand what happens in a stimulated cycle, we need to understand what happens in the natural cycle. Do we have luteal phase deficiency in the natural cycles? The answer is yes. We do have luteal phase deficiency in a number of cases of normal ovulation, and those patients need to be identified and given the luteal phase support. The progesterone, like other hormones, is produced in a pulsatile manner, and we need to know what is the pattern of estrogen and progesterone in the menstrual cycle. On the day of ovulation, the estrogen is at its peak, and generally the progesterone peaks 4 days, starts peaking 4 days after fertilization. The maximum after ovulation, the maximum level of progesterone is achieved on day 21. That's why we measure day 21 serum progesterone when we want to confirm ovulation. You know what's the production rate of estrogen? It is 0.6 milligrams per day in the cycle, and in the luteal cycle, and in the progesterone is produced at a rate of 25 milligrams per day in a natural cycle. What is the indication that this woman has a luteal phase deficiency in a normal cycle? Women who have shortened luteal phase, secretory phase, women with a short secretory phase suffer from luteal deficiency, and they need to be given the therapy in the luteal phase. What is it characterized by? The luteal phase deficiency is characterized by abnormal folliculogenesis, defective corpus luteum, and defective rescue by the corpus luteum, rescue for the pregnancy. And it is correctable if timely exogenous progesterone is given to all those who are suffering from this. This slide shows a detailed description what happens in case of the luteal phase deficiency and how it happens. It begins with the follicle. If you have poor follicular phase, then surely you will have you have less or defective FSH levels. That leads to defective follicle formation, and when there is defective follicle formation, it leads to poor production of estrogen and progesterone, and endometrium is not prepared for the implantation. What happens in the stimulated cycle and how they differ from the normal cycle? This is the slide of the day. The next, which is the slide which is going to come after this, is the slide of the day. You need to differentiate between the natural cycle and stimulated cycle. In stimulated cycle, you have multiple follicles, and estrogen progesterones are produced in supraphysiological quantity. Their duration is short. The peak stays for a shorter period of time, and fall is abrupt. And I will give you a comparison in this diagram. Can I have the pointer, please? If you look at the normal cycle, the rise in the production of progesterone is slow. It levels off at a lower level, and that level stays up for a longer period of time, and decline is slow as well. And if you take a stimulated cycle, the rise is sharp, it goes far above the normal levels, and it drops abruptly. That reduces the length of the luteal phase, and that luteal phase deficiency is common in the stimulated cycle as compared to the normal cycle. The big question: do we need luteal phase support for every stimulated cycle? The answer is no. Pregnancy can continue with IVF, with egg pickup, with stimulated cycles without giving luteal phase support. But the ratio is low, the proportion is low, and that is definitely enhanced with the use of the luteal phase support, and test tube baby or IVF is an expensive treatment. Hence, we do not want to miss a possible chance. Why the picture, hormonal picture or progesterone picture of the stimulated cycle is different from the natural? One, when we aspirate the egg, we aspirate the granulosa cells as well, and the vigor of aspiration determines what will be the outcome of that luteal corpus luteum in that particular case. The cycles which use GnRH analogs The GnRH analog blocks the LH production for a longer period of time, and corpus luteal maintenance is not possible or is not adequate in these women due to use of GnRH analogs. That's why the agonists and the antagonists are now being preferred over the agonist because they cause longer suppression. Number two, the estrogen and progesterone level declines earlier than normal. That's day 8 after the HCG injection. That's why it drops so quickly. The other things which we need to know about a stimulated cycle, due to this hormonal alteration from the normal, deviation from the normal, leads to a dyssynchrony in the endometrial histology. The stroma is advanced than glands. That is not suitable for implantation. Number two, we all must understand when we do the embryo transfer, people use tenaculum for that, valsalem for that. If we hold the cervix with valsalem, it generates uterine contractions. Even simple embryo transfer generates endometrial contraction, and those who are doing the procedure under ultrasound guidance would have witnessed that once we throw the embryo into the endometrial cavity, it flows up and down, up and down, up and down for some time to find the final place of implantation. And if we have concomitant uterine contractions, it may be expelled out and it may not stay in. Due to shorter cycle, if the menstruation begins, it interferes with the fertilization. If we talk about luteal phase deficiency, what is the end result? The end result is the endometrial implantation window formation is delayed by 2 days. And if we treat it in the same way as the natural cycle is, we will be transferring embryo earlier and the implantation will be not as good as it should be. Therefore, we must understand the luteal phase support helps us to advance the development of endometrium and delays menstruation, hence it favors implantation. What are the methods of luteal phase support? We are deficient in progesterone, so we give progesterone. Or we make the body to produce progesterone. The exogenous estrogen, progesterone, the idea of luteal phase support is not new. It was mentioned, discussed, and felt by the people who invented IVF. The two leaders, Edward and Steptoe, they talked about luteal phase support and why progesterone is beneficial. What are the functions of progesterone, how it makes implantation possible, how it promotes implantation. It says that it improves the endometrial quality, it increases endometrial receptivity for the embryo, it promotes vasodilatation, hence improving the nutrition of the conceptus. At the same time, progesterone reduces uterine contractility and improves the implantation. What are the options? There are vaginal gels, vaginal tablets, vaginal pessaries, suppositories, and injections are available, and they have been used for a long time. A new route has come in play now since dydrogesterone has been approved by FDA for this purpose. We now have 3 routes of administration of progesterone in the luteal phase. What are those? The first vaginal was a gel, Crinone, and it is widely used in USA. It has been used extensively in USA. It is given as a single dose, 90 milligram daily. It is convenience of usage rather than using it 3-4 times. It adheres to the vaginal wall and it is absorbed adequately, but it causes irritation of the lower genital tract. That is troublesome for those to whom it is prescribed, and we have got a better option and alternatives, endometrium tablets. Tablets make a foam in the vagina with the vaginal discharge, and they adhere to the vaginal wall, and they cause less irritation, and they are more patient friendly. Efficacy. Is any vaginal gel, suppository, tablet better than the other? The studies have compared them, and the conclusion is that all kind of vaginal progesterones available in the market, they are equally effective to each other. Therefore, we should look for the one which is more patient friendly and has less effects. Is vaginal better or intramuscular route better? The study says that pregnancy rate is higher with the intramuscular if we compare endometrium with the intramuscular progesterone, but the take-home baby is the same. In another study where crinone was compared with intramuscular progesterone, it clearly says that intramuscular has far better results as compared to the vaginal treatment. But you know, vaginal is convenient in terms of non-invasiveness. The injections, progesterone, are oil-based, and they cause problems at the site. Is progesterone alone is sufficient for the luteal phase support? Cochrane review says that if we combine it with the estrogen, the implantation rate would be higher as compared to the progesterone alone. And the best therapy in that case is HCG injections. You see, when estrogen is added, the result goes to 40% against 26%, and miscarriage rate goes down. What's the best estrogen to be prescribed? One is the progesterone directly given to the patient through any route. The second option is we give HCG injections, and that makes the ovary or the corpus luteum to produce more progesterone and estrogen, and it is compared far better than progesterone alone. But what's the limiting factor with the HCG? HCG can cause hyperstimulation. Hence, you cannot use it on every woman. When you are doing an IVF, you will realize that we have patients with 10 eggs, 20 eggs, 30 eggs. And if you have more than 10 eggs, you are likely to have hyperstimulation syndrome, and you have to be careful about it. So if you give HCG for the luteal phase support, she will have multiple cyst formation or retained follicle formation, which will have subsequently hemorrhage, and that may form the chocolate material type cysts. And then is the next question: when should we start luteal phase support, and for how long should we give luteal phase support? We should start on the day of egg pickup or the next morning. If we are giving injections, we can give injection on the same day. If we are using the vaginal, we can start the next day. If we are giving the oral, that can be started on the same day. The HCG injection is given twice a week. And how long should we give luteal phase support? Some people give it for till the result is positive. Others say when the pregnancy is seen on ultrasound. But the surest way of support is when we see the cardiac activity. So most of the studies and most of the advocates of luteal phase support are prescribing it for the 3 months till the pregnancy is strong to continue, even when it is discontinued. Do we have any other option for luteal phase support? Yes. GnRH analogs can be used in small doses as the luteal phase support. And the results are actually good with them. There is a claim of having 29%, 46% compared with 38% pregnancy rate. But it is still in doubt, and results are yet to come to support the GnRH analog as a continuous therapy, and then daily injection is a problem. Recipient cycle, do you know what is recipient cycle? When there is donor treatment which is not done in Pakistan. We were discussing at lunch about the ethics related to the IVF in this country, I want to make things very clear to you that donor sperm, donor egg, and surrogacy are not permitted in Pakistani law, and nobody should do it, and nobody should promote it, and nobody should support it, because at the moment, if any one center is caught or if any individual is identified promoting donor, that will affect the whole IVF system of Pakistan instantly, because हमारे यहाँ मीडिया बेलगाम है और एक केस प्रेजेंटेशन के ऊपर पूरा सिस्टम कोलैप्स हो सकता है। इसलिए हम जहाँ जहाँ हैं, हमारा ये फ़र्ज़ है अपने मुल्क के लिए और अपने डिसिप्लिन के लिए कि हम डोनर की बात को डिस्करेज करें, डिस्कस ना करें और इसके बारे में कोई इन बिटवीन बात ना करें। पेशेंट कोशिश करते हैं कि मैंने आपके कान में एक बात करनी है कि मैं किसी को नहीं बताऊंगी, और पेशेंट सबसे पहले बाहर जाके बताती है कि उसको कहना मैं किसी को नहीं बताऊंगी और मैंने किसी को नहीं बताया। सो वी शुड नॉट ट्रस्ट पीपल एंड वी, आपको पता रोने लग जाती है, मेरा रिश्ता टूट जाएगा, मेरा घर ब्रेक हो जाएगा, मेरी मदद कर दें, आपका क्या जाएगा। नेवर गेट into this emotional situation. So when we are not doing donor, but I want to tell you what happens in the recipient cycles. We prepare the endometrium of the recipient at the same time when the donor is being prepared for that, and the luteal phase support is given to those women as well. Third cycle, जो freezing and thawing शुरू होती है, इसमें आखिरी लाइन आपके पढ़ने की है कि 3 days पहले प्रोजेस्टेरॉन शुरू की जाती है, जिनका day 3 ट्रांसफ़र है और जिनका day 5 ट्रांसफ़र है, उनकी 5वें दिन की जाती है। Abbott has brought up a beautiful study about dihydrogesterone, and it is called Lotus 1. The intramuscular luteal phase support has its issues, that it is invasive, it can cause problems at the injection site. The vaginal has a problem, it's messy and it causes irritation. Oral is considered worldwide the best route of administration of any medication, but dihydrogesterone was not used for luteal phase support because it was not approved by FDA for this indication. It has gone through a big study which is called a Lotus 1 trial. The Lotus 1 trial was carried out at 38 sites in 7 countries and with certain objectives. क्या इसको luteal phase support में दिया जा सकता है, क्या इसका comparison दूसरी drugs के हिसाब से efficacy and side effects में कैसा है, और बच्चे के ऊपर long term and short term effects क्या हैं. 2 groups were taken in the study, one which was given micronized vaginal progesterone and the other which was given dihydrogesterone, and the total number of 1,066 patients were included, with 533 in each group, and they were matched in every respect. They were matched in every respect, in age, in demographic distribution, in their ethnicity, and the treatment was given in the same way, and they were compared throughout. And you know what came out of it. I will not go through these slides, but safety and tolerability, the side effects are not different from the vaginal or the other routes. The fetal malformation is not noticeable. And the conclusion is, this is the last slide I tell you, so you can relax. You know what it says? That Lotus trial says that dihydrogesterone is as effective as vaginal route and as the other routes. It is not superior, but it is not inferior to them, so oral route is an option. In conception rate, in continuation of pregnancy, in live birth rates, in congenital malformations, in other side effects, they are matchable. So oral dihydrogesterone can be used in the luteal phase support in place of the vaginal or intramuscular, and this study has actually gone to give you a hope that the oral route may take lead in the times to come. And I want to say it very loudly that in my center, Craft IVF, we are using dydrogesterone and cyclogest as the luteal phase support, and we are happy with our results and we have no complaints. So to conclude, luteal phase support and ART are going hand in hand, and it is best started on the day of egg retrieval. Injectable vaginal progesterones are time tested. Oral dydrogesterone is coming up with a great speed. GnRH analogs will yet take time to come up. Thank you, ladies and gentlemen.
अब तालियां काफ़ी थी या और बजा दें? I think और
Thank
बजा
you very
दें।
much, Prof. Arshad,
हाँ, मैं ले-
for your very informative talk about luteal phase support, especially generally speaking, all options of luteal support, and especially the new advances in the form of Lotus 1 trial. Prof, on a lighter note, Lahore is heart of Pakistan and Karachi is brain of Pakistan. Only if heart and brain work together, the harmony, peace, and success will come. So please join with us. So our next speaker is Dr. Naila Siddiqui Kamal. She is Senior Lecturer at Imperial College London, and she is Associate Director of Medical Education, Alumni of Imperial College and Harvard University, and she has recent interest, and she is key opinion leader in disruptive technologies in healthcare. Her topic is Futuristic Fertility. Please welcome Dr. Naila.
ठीक है ठीक है हाँ ऑन है ये ऑन है ठीक है बस Bismillahirrahmanirrahim. Assalamu alaikum. While they are trying to fix the pointer, I think I'd better get started. So first of all, thank you so much for inviting me here. Dr. Saab लाहौर से आए, उनको तालियों की कमी लगी. मैं लंदन से आई हूँ, तो तालियाँ तो बिल्कुल भी नहीं, लेकिन मुझे तालियाँ नहीं चाहिए. So it's always a pleasure to be in Pakistan and contribute in my little humble way things that very exciting things that I am involved in. I'm not associated with the advanced fertility discussions that are happening here. My background is in gynae cancer, but it has been either by choice, because I believe we should all be lifelong learners. So I never say my area of expertise, because I feel we are all on a journey, and from novice to expert, the expert phase never comes, because there's always something else that we should be aiming for. So I reinvent myself every 5-6 years. So the last reinvention has been in healthcare informatics. Very few people fully understand what that means, and often people associate that with maybe electronic medical records, EMRs as we call it. But there's a whole new world out there, and if I put it in a context, technology, we are in our 4th industrial revolution. So the first was electricity, first was the steam engine, then electricity, then the computers, and then the 4th one being that the machines are becoming intelligent. And we are at the cusp of 5th industrial revolution, where the machines will almost be like humanoids. So my reincarnation, or in a way, redefining my interest now, is that I am a key opinion leader in artificial intelligence and the role of disruptive technologies in healthcare. The reason that it's so important, and I'm very grateful for the organizers to invite me here, is the way we practice medicine, the way we will educate our students, and the way the patients will expect us to be looking after them is changing at a very rapid rate. Just to give a context about the change, in 1950, this is a study quoted by Harvard, in 1950, the amount of knowledge that we had in medicine, for it to double, it would have taken 50 years. In 1980, it was about 10 years. In 2010, it was 7 years. It's predicted in 2020, it will take 3 days. 3 days for medical knowledge to double. So is it humanly possible to know everything about medicine? It's not. And that is why it's generated a huge debate in medical colleges that we need to have a curriculum review. We need to make sure that what we are teaching our students is very relevant to how they will be practicing and what is really important. So without much ado, I am going to carry on rather than Ichal Nira beta. Ichal Nira. So these are my various different areas of involvement. I've taken out the expertise. At Imperial College as a clinician, this is a holographic image while I'm doing my first session in Obs and Gynae for undergraduates. I do the pelvis and the basic anatomy, but this is not a, what do you call, a model. This is a holographic image. So holographic image, hopefully, inshallah, next time Sadiah invites me, I will be holoporting myself from London, and I would not really be here in person. We are using Microsoft HoloLens, and that is the first humanoid robot called Pepper. It's being used in pediatrics, and this is a form of machine learning. There's a whole debate that is going out there that whether machines are going to take over and whether, machines are going to make decisions for us. I'd just like to, I need a whole session to go over that, but just as a reassuring fact that machines are not taking over. It's not like Matrix or some sci-fi movie. It's just that what the experts input, so algorithms, that's a term that is used, so whatever the experts are going to feed into the robot, you will have the expert level of outcome at a consistent level. So rather than variation between novice and expert and the variability in, so the patient, it's not going to be a postcode lottery that if he sees a patient A, a doctor A and a doctor B, the variability on there, so there will be, a consistency of expertise there. So coming to the context, fertility or subfertility, I don't like to label my patients as infertile. I don't like that term. So subfertility is a global issue. This is taken from WHO websites where the surveys were done, and it shows that, we can see there is a map across, the more darker, the bigger the problem, and they've outlined this. Now, I have to make a point before someone else from the audience, because I was in Islamabad presenting something different, sustainable development goals, and there was a map of the United Nations described Pakistan for the available data, and someone came out that when you are presenting in Pakistan, make sure that the map of Pakistan has got Kashmir in it. So I said that it's not a geographical map, it is a map which is showing that the data available was taken from this region. So before anyone actually, comes out. So futuristic, healthcare, or there have been milestones in healthcare which have been quite futuristic for its time. For example, when the test tube baby, it's been alluded to earlier on in a few of my predecessing sessions, that at that time was quite futuristic. And, the stalwart contributors have been mentioned in quite detail beforehand. Dolly the sheep, the cloning, the experiment that happened, the first somatic cell, which was used for, for fertility, and that was quite futuristic at its time. So it's not that, we are looking at the future management plans in a different way. So another milestone recently has been that first couple in America, 2013, first baby to be born through IVF as a result of next generation DNA sequences. So there are, in our previous discussions, quite advances in genetic testing prior to embryo transfer, et cetera, have been discussed, and they have all pointed out to technology. So what do we mean by disruptive technologies, and what is the role in futuristic medicine? So this is taken from World Economic Forum, that amount of investment that is going on. So global healthcare is spending about 7.7 trillion, and it's supposed to go up to that much amount in the healthcare industry. So like other industries, healthcare is a huge industry. And what are the key areas which will be involved in the future of health and healthcare? And we see here changes in healthcare delivery systems, the global health security, and the important bit that I am talking about is technology. Now, you may argue that we are clinicians. Why do we have to be familiarize ourselves with technology? We are not actually trained to be technicians. But things are changing. The important thing is that learning objectives which are actually overlapping both clinical world and the technology are being considered part of the clinical course, because the way we are going to be practicing medicine in some countries already has to have health informatics in our curriculum and a better understanding. And I'll tell you why this is so important. First, let me just go over when we talk about disruptive technologies, what do we mean? So there are two types of technologies: sustainable, disruptive. Sustainable, the same technology improves on itself and goes on, is the improved version. Simple example, your iPhone 4, 5, 6, 7, and now the iPhone 11 has just come out. Same technology, but improving on itself. But disruptive technology, I remember my grandmother's house, big gramophone, that big horn-like thing, and then the black record player. Then that went out, then the cassette players, then the CD players, iPods. What else? I don't know. I have to look at my son's new gadget to find out what is the latest thing, for which I'm the funder. So anyway, so that technology, the latest technology, who has seen cassettes around? I know that my husband still has CD players, so he's pretty historic himself. So there are, disruptive technology means that the previous one is just gone, 5 minutes, and the new technology has come in. The ones that you need to be looking out for: artificial intelligence, Internet of Things, connectivity is the main thing, blockchain, and robotics. I'm not going to go into the details of this, but let's just talk about artificial intelligence. First of all, it may, AI, for this cohort of people, AI would automatically mean artificial insemination, yes? Or assisted insemination, or what? What is the word that you, so please, I'm not talking about that AI. This is artificial intelligence as a part of a disruptive technology. This slide is simply showing that this is the most important or common context of research and development. Again, lots of research that is happening. Important thing that I think it's important to mention here is, and it was alluded to earlier on, that one shoe does not fit all. What does that mean? We are talking about precision medicine now. In a lot of articles that you will read, they're talking about precision medicine, preventive medicine, we've been talking about before, but predictive medicine. Now, it's not just the patient's social attributes that make that particular management individualized. Take a step before. When Sadiah was talking about wellness, or the woman's lifeline, the 7 stages according to Shakespeare, starting from birth, I would say go one step before. The health actually starts from intrauterine life. So going through that phases, if you had technology that will, using artificial intelligence with a system such as IBM Watson, which is the big data, where you have algorithms, and it tells you exactly that patient A, for example, I'm the patient, and I need some treatment. According to precision medicine, the data that is around me will tell exactly which medicine is going to work for me, what is its success rate, how will it impact me. So that way, you will have better control on the outcomes. How things are affecting your domain, you can see these electronic solutions that are coming up. online calculator, how the prediction of IVF treatment that is being given according to the patient's variables that are here. When you fill those up, it gives you a success rate. So machine is calculating this. The machine will, and again, precision medicine. For example, personalized ovarian stimulation. That means whether this woman is going to have a successful outcome or not, if you have the right algorithms fed in a big data using artificial intelligence, you will have better outcomes. And as you can see, this is not something out of the blue I'm talking about, why the future of precision medicine runs through the IVF lab. And again, a lot of research which showing that you can test things like the viability of the transferred embryos, more than 70%, and with time, this is improving even more. Again, if there is a right algorithm that is fed in the in the AI-based solution, then you have 97% accuracies as to, compare, machine has 97% accuracy compared to experienced embryologists. This does not mean that we are going to make ourselves redundant because machines are going to be playing a big part in clinical healthcare. We will have newer roles. Remember, the machine is an expert only because the experts have fed in their expertise into the machine. So that's a very important point, that first step towards that adoption would be that we start acknowledging that robotics, artificial intelligence, augmented reality, virtual reality, these are all solutions that are there to help us look after our patients in a much more effective, evidence-based and precise manner. So my plea to the audience would be to please read up on these things, especially those who are thinking of sitting for exams outside, even here, that this is very soon going to be part of the curriculum, if not, or your examiners definitely will be asking you about. My last slide is, this is a map of a smart city. I'm hoping that the Karachi Municipal Corporation takes that, I can easily share it with them. And you can imagine that here everything is digitalized. So you have your healthcare digitalized, your patients, with personalized devices connected to the, the clinicians, the hospitals, et cetera, et cetera. It's very futuristic, but it's already happening. And this is the version or the map vision that we should be working towards. So I think I've taken up the little time that I was given. So thank you very much.
Thank you very much, Dr. Naila. The idea of artificial intelligence, precision medicine is new for most of us, but it looks like that this is our future. The idea is very exciting. So I like, for closing remarks, I like honorable Chairpersons, either Dr. Lubna, whoever want to volunteer for the closing remarks, please.
First of all, let me thank the organizers, my very, very good friend, Sadiah, who I've always considered a friend, except that putting me on the stage in a post-lunch session is not a very friendly thing to do. And then, or maybe she just wanted to make sure that I wouldn't disappear. But anyway, coming to the session, honestly, it kept me awake. And I didn't for a minute regret that I was here and stayed here, because each of the topics was really interesting. The last topic took my breath away because futuristic infertility or fertility is somewhere, that is something I can't even think about because where I come from, half the female population is perceived to be infertile. Never mind that the little girl got married a month ago and her husband is not there anymore, he's gone abroad. So we are battling with that sort of a thing. I wish that we could somehow come together to socially combat this thing that is really, really prevalent here. One short question from, if the picture's been taken? Okay. From Professor Farrukh. Do you have the addresses of all these centers who are doing IVF at the back of your little book? Because, you know, referral is a huge problem for us. I'm a generalist, and we, from time to time, need to refer a patient that we think now needs expert care, and we are constantly then shoving and writing on pieces of paper. So if you could, at some stage, add, you know, the contact numbers and this thing, that would be a great thing. So all in all, I think this was a great session. And I thank you very much. And after this, do you want an announcement for tea or something? Or are we done?
If you want to say anything more, then yeah. I just want to share something that I've heard you say, that in your practice, whenever a woman comes with infertility issues and she's got a couple of babies and you say, oh, baby, tumhare ande khatam ho gaye. End of the story.
Okay, I say that when she's...
Okay. But that's, I wish we could all say that, ke bas end of the story. Yeah. Thank you very much.